Everybody, thank you very much for coming to this very special symposium on the management of pulmonary embolism in World Thrombosis Day celebrations run by Thrombosis UK. I'm Professor Beverley Hunt. I'm founder of Thrombosis UK, thrilled with how it is. I think this is a really important symposium, and I'm delighted to introduce to you my co-chair, Dr. Karen Breen. She is my partner in crime at Guy's and St Thomas's, and she is one of the co-directors of the haematology service. And she and I have been working together for many, many years on thrombosis. Karen really does major on antiphospholipid syndrome. So where are we starting from today? Well, Thrombosis UK has a lot of concerns about the management of pulmonary embolism. I think the first one is that people forget that pulmonary embolism can present in so many different ways, and that quite often patients with typical symptoms are not triaged into the pulmonary embolism pathway. And then we have the issue that we have now developed complex management of pulmonary embolism. And I look back and I remember when I used to manage myocardial infarction in the early days, you just put them to bed for 3 weeks. And of course, we don't do that anymore. We have a complex series of things that we can do for them. And the same is happening to pulmonary embolism. And we have a new classification. And as a centre where we accept patients for thrombolysis from the whole region, we're very aware that people are a little bit muddled about what is intermediate risk PE and what can we do for those patients. And I hope very much that we will have some clear answers for you at the end of the symposium. And we're going to cover all aspects, and I'm going to hand over now to Dr. Karen Breen to introduce our first speaker. Thank you, Karen.
Thank you, Beverley, and good morning to everybody, and thank you very much for attending today. So first up, we have Dr. Raza Alikhan, who for many of you will not need very much introduction. He's a consultant haematologist based in Cardiff, and he's done a lot of work in VTE prophylaxis and treatment, and I know his particular interests are around bleeding with DOACs and cancer-associated thrombosis. So today, Raza is going to talk to us about low-risk pulmonary embolism. So Raza, over to you.
Good morning, Karen. Thank you to both yourself and Professor Hunt, and also Joe from Thrombosis UK for this invitation to speak today. I think it was very interesting, actually, just hearing Beverley mention how when we were first called as junior doctors to see an acute MI, we'd essentially tuck them up in bed, and you know, there wasn't really much, and then thrombolysis became this sort of amazing new therapy. I can remember as in my first job as a houseman in medicine, my task was to clerk in the DVTs. The SHO would clerk in the suspected PEs, and then I would spend the night dosing the heparin and measuring APTT ratios. And as we move through the decades, literally, DVT patients now, we ambulate pretty much all of them. And I can remember in the last couple of weeks trying to admit a DVT patient and having a junior doctor say to me on the phone, you do realise we don't admit DVT patients. And I'd like to sort of get you thinking somewhere similarly about patients with low risk PE. When we first started ambulating DVT patients, I can remember, you know, we used to put them in bed for 5 days, strict bed rest, and colleagues would say to me, you know, if you send these patients home early with a DVT, they'll literally drop dead. And I've heard similar concerns about the management of patients with pulmonary embolism, particularly low risk, about the risk of sending them home. And so what I want to do is just take you through a case history. This is a patient I'm going to present. It's a young lady. She's an amalgamation of a number of patients I've looked at, because she helps highlight a few useful points. But essentially, she presents in primary care. She's in her mid-20s. she's got a mild cough, little bit of breathlessness, a low-grade pyrexia, nothing really to hang your hat on. Basic, but sort of borderline, basic obs. She's got a mild pyrexia of 38, a pulse just tachycardic, her SATs are essentially okay on air. The only thing of note is that she's on the combined oral contraceptive pill. And so the questions that arise here are, should we assess this? Should we be thinking about pulmonary embolism? I think that's the first thing. Should you have PE on your mind? And if you do, what should you do? And I've put some suggestions here in terms of options to manage our patient Geeta. And I think essentially all of them are correct. Perhaps it's a bit reflexy to put us straight on to anticoagulation, but if you have concerns, you could refer to secondary care. But I would suggest that she needs a risk assessment, and a couple of risk assessment scores that are suggested here are the PERC rule, which is the pulmonary embolism rule out, or the Wells score, named after Philip Wells some 30 years ago. He first presented this risk score. And so on the left-hand side of your screen, what I have here are the features of the PERC score. You don't need to remember these. Many of you will have apps on your phone or on your desktops that will allow you to calculate the PERC score. And in Geeta's case, she's got a pulse of 101 and she's also on the pill. So she actually has a PERC score of greater than 1. And therefore, we're unable to rule out PE based on this PERC score. And if I take you back to the 2012 NICE recommendations or the guidelines for a patient who had a suspected PE were that they should undergo a 2-level risk score using the Wells score. When we talk about 2-level risk score, the original Wells score actually had 3 levels of risk: a low, intermediate, and high risk. The 2-level score, what that actually means is it's either likely PE or DVT if you're using the Wells DVT score, or unlikely. It's a dichotomy. There's no sort of in between. You either suspect PE or you don't suspect PE. The PERC score talks about gestalt. It talks about if you have a low suspicion, less than 15%, then you can use this score. So in this case, Geeta's PERC score is greater than 1, so we can't rule out PE. And she's therefore referred to the emergency department, which I think is appropriate in her case. And so many patients referred to the emergency department go through a triage system. Sometimes they get a whole heap of blood tests done. Sometimes they may go straight into imaging. Again, depending on how long it's going to take to see Geeta, you may want to consider initiating anticoagulation. But again, if you're seeing her in an emergency department and you're able to assess, get blood tests done or imaging within 4 hours, then I think it's still reasonable not to initiate anticoagulation. In this lady's case, I would take her further for risk assessment, and I would take her through a Wells score. And again, this is Philip Wells's likely or unlikely, so 2-level score. Again, you will be able to access this on an app on your phone or on a desktop. And when we risk assess her, the only thing that comes out strongly or as part of the risk score is her pulse. My difficulty, or one of the difficulties working with the Wells score and the iterations that come on after the Wells score, such as the years score, is the row above. The alternative diagnosis is less likely than PE. That was far more subjective. And if you were seeing Geeta in the emergency department and you had a strong feeling she'd had a PE, you might score her 3. With her tachycardia, she then scores 4.5, which is PE likely, and then you would move on. But in this case, I've still got a low suspicion that she's actually had a PE, but she is tachycardic. And because her PE score is unlikely, we then have a situation where we have a positive PERC score, but a negative Wells score. And so again, do we go on to imaging? Do we start anticoagulation? And in this case, I think a D-dimer test can be helpful. And so if you look at the bottom of the page, what you'll see is her D-dimer reported, in this case in micrograms per litre, but in your hospital, it may be recorded in nanograms per milliliter. And I think what's important is that you do the Wells score first, before you do the D-dimer, rather than coming to see the patient at assessment with a blood test that's positive, a raised D-dimer or raised troponin, and then trying to differentiate the causes of her pain, of her breathlessness. The whole value of the Wells score is in terms of its negative predictive value. So if she had a Wells score that was less than 4.5, so an unlikely PE, and she had a normal D-dimer, then the Wells score has this high negative predictive value of more than 99%. And you can use it in that way. If you come to the patient and you're told there's a young lady in the emergency room with a D-dimer of 10,000, you're already on the back foot, because we've seen over the past couple of years, particularly with certain respiratory viral infections, that you get very high D-dimers and breathlessness and possibly tachycardia and even pleuritic pain. And so the D-dimer in that case does not help you in your assessment. So if we look at the 2020 NICE guidelines, we suspected a PE, we did a 2-level Wells score. If the score had been greater than 4, we would have gone immediately to imaging. In this case, the Wells score was less, PE was unlikely, so we measured a quantitative D-dimer. This is elevated. The cutoff in this particular example was a level greater than 500. And so again, we move forward with this question about imaging or anticoagulation. If you could image the patient within 2 to 3 hours, or NICE would state 4 hours, then you go through to imaging. If there's likely to be a delay, I would suggest that this patient receives a stat dose of anticoagulation. And so Geeta has her CTPA, and to orientate you, she's lying on her back. The big lump in the middle is the heart. Right-hand side, your right lung, left-hand side on the screen. Well, in fact, yeah, okay. And so the arrows are pointing at filling defects. So this is a CTPA. She's had contrast, and what we can see are filling defects in both sets of pulmonary arteries. And we follow her down a little bit lower, and you see we're moving from the right main into the segmental branches on the left hand of your screen, so her right lung. And there's also a filling defect on the right hand of your screen, so her left lung. So we have bilateral PEs here. I'm going to refer a couple of times to a number of guidelines, one, the NICE guidelines, but also there are some very good pulmonary embolism guidelines that were published in 2019 by the European Society of Cardiology. And so we have a patient now with an acute PE, and we're going to commence anticoagulation. And historically, we would have given this patient heparin or low molecular weight heparin more recently. But if we move forward and look at the guidelines from the ESC in 2019 and also the updated 2020 NICE guidelines, we see that ESC recommend the use of a DOAC, and NICE go one step forward and actually specifically recommend either apixaban or rivaroxaban if we're going to go down the DOAC route. And the reason why they've gone for one of these two anticoagulants is because we don't have to lead in with 5 days of low molecular weight heparin. And so that has the advantage, or the potential advantage, in our low risk patients in terms of facilitating our ambulatory care. If we go back to the ESC guidelines, we need to identify and risk assess the patient further. Professor Hunt touched on intermediate risk PE. I'm talking specifically about low risk PE. And so there are a couple of scores or assessments that we can do to try and identify the low risk patient. And these include the PESIS score, so the Pulmonary Embolism Severity Index, or something called the HESTIA score, and I'll talk you through those as well. In terms of RV dysfunction, this may be done either by an echo or could be used or done on CT criteria. If the patient is identified to be at low risk, they can be considered for early discharge home. And I think that's very important, particularly in this day and age, and particularly with some of the pressures that we are facing at the front door in secondary care. In addition to the NICE, in addition to the ESC recommendations, NICE have also added in a recommendation about using risk assessment to assess patients with low risk PE and to consider them for outpatient management. Remember, these are the patients that we were admitting when I was a junior doctor for at least a week on IV heparin, strict bed rest, and now being considered for outpatient treatment. And further supporting this are the British Thoracic Society guidelines, the outpatient management guidelines from 2018, and the quality standards that were written in 2020. And again, they refer to these risk scores, the PESIS score and the Hestia score. And I just want to present a couple of studies to you where we've used Hestia and Hestia to assess patients for ambulatory PE care. So what is the PESIS score? So again, I'm going to point you to the app on your phone or your desktop. The PESIS score, the original PESIS score, is a little bit more complicated. What I'm presenting to you here is the simplified PESIS score, which is made up of 6 criteria. And you can see that Geeta has none of these. So she has a low risk simplified PESIS score. Now, it's important to be aware that the PESIS score was not developed to identify patients who could be discharged. It was actually developed to try and identify patients who are at high risk of mortality at 30 days. But it has been adapted to be used in this way, and it has been validated subsequently to show that it is a good way of assessing your patients. And so the first study I want to present is the Alpha PE study, which is a study that we did with 4 hospitals in England, 1 in Glasgow and 1 in Cardiff. And the reason why we did this was we wanted to see if introducing a DOAC, and we picked one DOAC, and in this particular study, it was apixaban. We wanted to see if just changing the anticoagulation therapy for patients had an impact on hospital stay. So these were hospitals that were identified who didn't have an ambulatory PE pathway in place in 2013 or in 2017. And prior to doing the study, we did some CPRD work in England, and in 2013, the average length of stay in a hospital in England for a patient with a pulmonary embolism was seven days. And so we wanted to see if we could reduce the length of hospital stay for patients with pulmonary embolism down below 7 days, just with the introduction of a DOAC. So nothing to do with ambulatory PE pathways, risk scores, etc. We wanted to see if that had occurred. And if you look on the left-hand side, you see that within the 6 centres that contributed to this study, this is the interim analysis of just the hospitals in England. What we saw was that in purple in 2013, the average length of stay was 7 days in those centres. So very much in keeping with what had been seen across the country. And the majority, in fact, almost all of those patients, more than 3/4 of them, in fact, were started on heparin and warfarin. Whereas when we move to, still looking at the left-hand side, when we look at the green plot, you see that the length of stay during the study, just by the introduction of DOAC, had reduced down by almost 3 days. And when we did further assessment and we followed this study up further, on the right-hand side, you'll see that the big driver for the reduction in hospital stay was patients with a low PESIS score. But these patients were still spending at least 2 to 3 days in hospital with a low PESIS score. So that was a study that we did here in the UK, looking at apixaban. And this is the hot PE study that was actually done with rivaroxaban, slightly different model. This is prospective, using the licensed dose of rivaroxaban, and patients were only able to go into this trial if the plan for hospital stay was less than 48 hours. And the inclusion criteria for going into the study, apart from the fact that they'd had a PE, was the use of the Hestia score. So in Alpha PE, we use the PESIS score, and in the hot PE study, they use the Hestia score. And on the right-hand side of your screen, you see what, or a modification of the Hestia criteria are. So patients who have hemodynamic instability, who've been thrombolized, who are bleeding, who require oxygen, already anticoagulated and having a PE on anticoagulation, pain control, patients there are other criteria in terms of social and safety in terms of being managed as an outpatient. But essentially, so these patients had no Hestia exclusion criteria, And the plan, the study was powered to look for about 1,000 patients with an interim analysis at 525 patients. Looking at recurrence, so this was a safety study as well to show that it was safe to send patients home, and it was powered up to a recurrence rate during the study of 3%. I'm not going to go through all the details, but essentially, in terms of the recurrence rate, it was less than 1% for these low risk patients during the first 3 months, and actually the study stopped early because it was shown to be safe to discharge these patients. And so we have 2 studies, one with a apixaban that shows that the introduction of a DOAC reduces length of stay, and with the alpha PE rivaroxaban study, we see that it's safe to discharge low risk patients early. So again, but within 48 hours. And these support the recommendations that we see from NICE, which recommend in 2020 that for patients who are being ambulated, they should be considered for a DOAC, and specifically apixaban or rivaroxaban. And this is prescribing data from England, and you see we've gone from 2013 to 2020. The majority of patients in 2013, these are non-cancer patients, by the way, the majority of patients in 2013 are starting warfarin, so that's the blue line. And you can see that as we go across time to 2020, the majority of patients now in this study in England are either starting rivaroxaban or apixaban. So more than 90% of patients are being started on a DOAC, and these 2 DOACs specifically. So we see that prescribing habits in the UK are actually reflecting the NICE guidelines rather than the NICE guidelines actually influencing prescribing. And the alpha PE and the hot PE studies both support a reduction in hospital stay, and also support a safety analysis. So back to Geeta. We've got all the evidence. You're now faced with Geeta. She's come in to her GP this morning. She's arrived in the ED at 11 in the morning. You've scanned her. You're now reviewing her on your sort of afternoon ward round at about 2 o'clock. What would you do with her? She's got a very high D dimer. Should you keep her in overnight to observe her? Should you bring her in and do further investigations? Or can you send her home the same day? And I think these are the conversations that we're having almost daily with patients who are low risk. And I saw a patient very similar to this only last week, and she was actually sent home that afternoon, had spent less than 12 hours in the emergency department. And that would be how I would manage this lady's pulmonary embolism. She's got an PESIS score of 0. She fulfills all of the Hestia criteria. It is safe to discharge her on a direct oral anticoagulant. And although this is outside of the scope of the talk, I just wanted to mention this bit at the end. She's on the combined oral contraceptive pill. And again, there seems to be this reflex action in the emergency department to stop the pill because this could be a pill-associated clot. What I would encourage our audience to do is actually carry on with the pill, particularly while you're loading her. You may be giving her 3 weeks of high-dose rivaroxaban or 7 days of high-dose apixaban. Keep going with the pill, particularly for those first couple of months. What we don't want to do is create further problems with heavy menstrual bleeding. If at 3 months you're going to review this patient and stop her anticoagulation and risk assess her further, then you can consider alternative hormonal input. That may be controversial, but that is how I would manage Geeta. And at that point, I'm going to thank you for your time listening, and I'm going to hand back to our chairs. Thank you.